So we're talking about different causes of altered mental status. Hypoglycemia is a pretty important one because it can mimic both a stroke and a seizure and then has its own symptoms as well. It is possible for patients to experience hemiparesis, so that um, one-sided weakness in the body. The difference is that a patient who's had a stroke may be alert and attempting to communicate normally, whereas somebody that's hypoglycemic really has a pretty altered mental status or a decreased level of consciousness. Um, Typically, those that experience hypoglycemia have medications that they take to control their blood sugar, and they either took too much or didn't eat appropriately after they took their medication. That's not always the case, but that's pretty likely. Um, if a patient is hypoglycemic, they can also experience seizures, which makes it even harder to figure out what the heck's going on. Um, if they are hypoglycemic and that leads them to a seizure, they often don't improve well after they have that seizure-like activity because it's something more than just their brain that's causing that. They have an underlying issue. So somebody that has a seizure that's not recovering quickly, go ahead and check a blood sugar on them. Um, Definitely consider hypoglycemia as being a confounding factor when somebody who is in a traumatic incident and there's really no legitimate cause for it that you can see. It can be that medical precedes trauma emergencies, so they may be hypoglycemic. So oftentimes on our trauma patients, we do check a blood sugar a little more often than not, just to make sure that that's not part of the problem as well. Kids also are really, really susceptible to hypoglycemia even if they have no history of diabetes. Kids don't have the reserve stores that an adult does. So anytime their metabolic rate increases because of illness, distress, being under stressful or traumatic conditions, they tend to burn through what little stores they have. So we are very vigilant about checking blood sugars on kids. Delirium, this is a symptom. It is not a disease in and of itself, but it often presents as a new, like acute type complaint rather than a long-term behavior alteration. It's a temporary state that often has a physical or mental cause underlying. It could be infection, changes in medication, can be hypoxia. It just kind of depends on what's going on. And if you can fix whatever's the underlying cause of the delirium, it typically is very quickly reversed. Some signs and symptoms include confusion and disorientation, disorganization of thoughts, the inability to focus or pay attention to something, memory loss, like massive sudden changes in personality or the way that they behaved, which is also known as their affect. Hallucinations, delusions can also be just a decreased level of consciousness. Um, Patients often experience a pretty rapid alteration between the mental status of lethargy and then agitation. They kind of tend to pop back and forth. Symptoms of delirium often mimic like people that are intoxicated or have taken drugs, can also kind of mimic um, mental health issues. So just kind of be aware that there can be medical causes behind some of those mental changes. Some other common causes of altered mental status is an unrecognized head injury, um, severe intoxication for sure, but you need to consider other problems rather than just alcohol. It doesn't necessarily mean because they smell of alcohol that they are super severely intoxicated to the point where they're altered. There may be other factors there too. Psychological disorders and medications that they put on for those disorders can often cause altered mental status. And then infections, especially those that involve the brain or the bloodstream, can cause huge altered mental statuses. Example is little old ladies that tend to get a urinary tract infection often are profoundly altered. Not saying that all of them, but they do tend to be more that way. Whereas if somebody your age in high school were to get a urinary tract infection, it would more just be super annoying, the fact that you have to pee all the time. So some differences there. Patient assessment, your scene size up is just like with everything else. Looking for clues, trying to help the patient out. Oftentimes, they're going to have a family member or a bystander there that's well more upset than they are because they're altered mental status. They're just kind of possibly out of it. They don't really truly understand what's going on, and they can't reliably tell you what's going wrong. You need to be very vigilant for looking for clues of possible trauma to make sure that we don't need to take spinal immobilization precautions. Then we're going to move on to our primary assessment. Primary assessment, again, is looking at life threats. To perform a rapid exam on anybody that is altered just to make sure that you're not missing something. You want to give somebody that's got an altered mental status some high flow oxygen. The brain very sensitive to changes in oxygen. So if we give them a little bit of oxygen and they pop out of it, then we are pretty assured that that had something to do with why they're obtunded, is what we would call that. That's a fun word for it. Don't hyperventilate. That's something that we used to do in the past because it does cause short-term improvement in those that have increased intracranial pressure, but the longer-term effects, and longer-term I'm talking after just a couple of minutes, can be severely negative. So we don't hyperventilate anymore. We might keep them at the higher end of normal, but we don't truly hyperventilate like we used to. For your history taking, we're going to try and investigate their chief complaint and get more information if they can give it to us. If there's nobody around, kind of look for quick explanations, such as things that would signify a stroke, hemiparesis, seizures. Oftentimes they are incontinent or they bite their tongue or their lips, cheeks, something in their mouth as they go down because those teeth are going to clench because of the sudden increase in muscle activity. And oftentimes whatever tissue's in the way gets taken out. So oftentimes they have bit their tongue. So that can kind of help you out there. Try and get a sample history. Oftentimes when we're talking about patients that are having neurologic disorders, it can be a stroke and time is brain. So that may be something that we're going to get en route rather than taking that on the scene. Secondary assessment, you want to do your physical assessment just to make sure that you're not missing anything. Paying really special attention to things that are involved. If you suspect the patient's having a stroke, make sure that that's where you concentrate first. Your vital signs, patients with significant intracranial bleeding may have a great deal of pressure in the skull that's actually pressing down on that brain. This causes the pulse to slow down, causes very erratic respiratory patterns. The blood pressure is usually pretty high. Your body tries to compensate for the lack of perfusion in the brain by trying to increase blood pressure to force more blood up into the brain. It's actually kind of a catch-22 because that ends up increasing that pressure and decreasing the amount of perfusion in the brain. And then all of a sudden your body is continuing to hike up that blood pressure, trying to fix the problem and just making the problem worse. It's a very vicious cycle. You can see unequal pupil size or lack of reactivity if there's significant bleeding or significant pressure on that brain. So we do check the pupils. Depending on which side of the brain, it may affect one eye and not the other. So typically we're going to have one pupil that's going to be normal and reactive, and the other one is going to indicate that there's a problem up in the brain. Check your blood glucose levels on any patient that's altered or any patient that you think is experiencing a stroke. A lot of times, a patient that's experienced a seizure, they're going to have relatively normal vital signs other than kind of their respirators trying to compensate for that CO2 retention while they were having their seizure. Don't take vitals in the middle of a seizure. Oftentimes you're not going to get good readings. So give them a chance to kind of do their thing. And then when they start coming out of it, start assessing your vitals. But again, be careful. Your patient might become combative as you start messing with them. Utilize your monitoring devices. Non-invasive blood pressures is a good way to check somebody that's post-ictal, because then if they lash out, they're lashing out at a machine and not you trying to take a manual blood pressure. Stroke assessments are very important. There's several different types that you can see up here on the screen. We tend to actually use a combination overall of a couple of different ones, but they all could go to the same area. So the most common are the Cincinnati pre-hospital and the Los Angeles pre-hospital. We're going to try and test speech, asking the patient to just go ahead and repeat a very simple phrase, testing for symmetry and movement in the face. So you can have them smile, stick out the tongue, testing for arm movement, trying to see if one side of the body is symmetrical to the other. Have the patient hold their arms, both of them out in front of them, palms up, and then close their eyes. You can help support their hands out in front of them until they close their eyes, and then move your hands and see if one arm drops, or if they can maintain both of them up, or if both of them drop at the same time. The 3-item stroke scale looks specifically at all 3 items, so the level of consciousness, the arm drift, which indicates motor function, and then the gaze. Your fast mnemonic is for facial droop, arm drift, speech, and time. All patients with an altered mental status should also go through a Glasgow coma scale and then check for reassessment as well. I'll show you the table here that kind of goes through the different portions that you're going to check in your stroke scale assessment. Here's the Los Angeles stroke scale. Here's your 3-item stroke scale and your Glasgow coma stroke, or not stroke scale, just your Glasgow coma. This is anybody that you're trying to get a generalization of how they're doing. 15 is the best that you can get. 3 is the worst that you can get. So that kind of indicates where they're at as far as their dysfunction. And we'll go ahead and stop there.